Welcome everyone. I hope you've been well since I last saw you at the Northwest Yoga Conference. This is an overview of some of the work we did in the hip class called The Tiny Universe Inside Your Hip Sockets. And I've chosen pieces of this conversation related to hip replacements, and some of you asked about that. It also does apply to the sacroiliac questions that you asked and some of the other myofascial considerations. This is a lean presentation in terms of what's really available to us as yoga therapists and practitioners, but it's what I can provide within this particular framework. What I don't have in here are the medical illustrations for the hip surgery, the hip replacement. What I'm not able to include in here are the medical illustrations of the sacroiliac joint or the pelvic floor. But what I am able to give you here is an overview of the class that we had and a reminder about how some of the practices got put together. So the first consideration that we had was assessment. And for me, as a yoga therapist, what I'm really assessing most in dwelling is the quality of the person's attention. And this brings into our awareness the manomaya kosha, comprised of the senses, the sense impressions, mental patterns, and what we call at my studio the 6 stations of the mind. That is, where is the mind at any one moment, going between past and future, self and other, likes and dislikes. The quality of attention is also that which we're cultivating in the practices of mindfulness. And deeper than this intention in the model of the koshas is what we call vijnanamaya kosha, where we experience this quality of wisdom and intuition, a quality of like clairvoyance that our ancestor yogis had. They had that enough that they could feel and hear the Upanishads. They felt and sensed the koshas, the chakras, the doshas, the vayus, the marma points. So deeper than our quality of attention in the practice lies our access to that same experience of wisdom, intuition, and grace that our ancestor yogis had when they developed the practices of yoga and then put them into a context that we're still learning from today. Now, even deeper than Vijnanamaya kosha is what we call Anandamaya kosha. And that is that shimmering presence, that radiance that you sense. Often we sense it in the changing light of the day at sunrise or sunset. Those are considered to be sattvic periods in the day. And when you sense that ananda, it's the feeling of belonging, of homecoming, of being welcomed, to recognize that you already exist and life is already caring for you. You're already invited to be here. Now this ananda is non-divided. It's also not capable of being compartmentalized, nor is it broken, damaged, nor flawed. Of course, at the physical body, we experience symptoms like pain and inflammation and asymmetries and so on. But at the level of the Anandamaya kosha, it's the indwelling wholeness, radiance, and belonging. Our bodies come into the world with a body intelligence that already knows quite well how to take care of us, though most of us have health problems because we aren't so in tune with that body intelligence. So the practice of yoga is to help us come back to this body intelligence and to have access to that, to recognize it. We need the quality of attention that is sattvic. So sattva is one of the 3 gunas, and it means that which is clear, that which is lucid, that which is true, that which is expansive. Next is the quality of our efforts, and we start blending the manomaya kosha with the pranamaya kosha. So the quality of effort, I like to call this elegant effort, an elegance in the effort, also linked with the breath. So when we meditated in the beginning of the class, we were feeling into the pulsation of the body that already existed. We're going to do that for just a few moments right here so you can remember it and have access to it again. So wherever you happen to be, sitting, lying down, standing, bring some attention into the places where you're right now connecting to the ground beneath you. When you connect to those places of sensation, including a little bit of density, where you meet the floor beneath you, and a little bit of texture, maybe between your shoes and the floor or your hips and the chair. To practice attention for this, we need the mind to be less distracted. And using the quality of attention that is non-distracted and non-judgmental, now shift your attention into the experience of your hands, wherever they happen to be, whatever your hands are experiencing. And see if you can sense in here the quiet pulsation of your body intelligence taking care of you. You might feel it as your heartbeat. It is a rhythm, a pulsation. It does not need you to coordinate it. You don't have to remember to tell it to function. And yet, it's responding to every thought and thought impression that you have. When you bring your awareness to this pulsation, you invite the possibility of greater wholeness or homeostasis, health. Now, as you notice this, try to keep your attention resting on this with appreciation and respect, and start the quiet process of deepening your breathing. And here's where your effort has to become more elegant. The rhythm you feel in your body, the pulsation, and the rhythm of breathing, we ought to be able to maintain attention on both of those things at once. At least in meditation, right? That you can feel this quiet, pulsing rhythm and the lengthening and steadying of your breath cycle. So we don't even breathe so vigorously that we're disrupting our access to that rhythm. And when you come into moving poses, moving asana poses, we're going to be still seeking elegance in action, elegance in effort, and to connect the breath with the body. You may have less sense moment to moment of the pulsation in your body, but I'd like you to keep your awareness on the fact that it's still going on. Let's transition from meditating to look at a couple other things on the slide here. So we're really interested then in the Annamaya Kosha, the muscle and bone body, that there's a smoothness of movement linked with the breath. And as a yoga therapist or a student, we are observing when it becomes choppy, lethargic or dull, staccato or sluggish. Those will be signs that the Pranamaya Kosha is trying to tell the Annamaya Kosha about something happening within the system, the intelligence of the system, and we want the mind to notice it, not to override it. We also look in our assessment, in some movement and breath and stuff, we look for the onset of escape hatches. So if you're in cat pose and you're going back to half child's pose and coming forward to cat pose and so on, if you're doing any kind of movement, you're watching to see when do the hips veer left to right. When is there a kind of swivel or an escape hatch occurring? We do have to slow down to catch a glimpse of these things. We're also looking for the relationship between the femoral head and the acetabulum. And just to take note that acetabulum does not have an S in it, so that's a typo. It's pronounced the same way. So the femoral head is the round part of the thigh bone that goes into the hip socket, which is also round. It's a ball and socket joint. And the size of the socket and the size of the femoral head do make a difference, as does the orientation of the acetabulum, if they point more laterally or more anteriorly, a little bit more down, a little bit more up. That all makes a difference in the range of motion in the student's hip socket. And it can be different left to right. There are asymmetries in the design of the body, and often it shows up as asymmetries in the physical asana practice. And we're looking for those asymmetries that are starting to get the attention of the student because they become larger symptoms. So some of the things we did for assessment in the class that you took, we used cat pose to half child's pose, to cat pose, to cow pose. And here we were still looking at having that elegance in your sattvic attention and the linking of the breath with the movement. And then once we got that tranced, we were playing with putting one knee slightly forward of the other. And repeat the same sequence, cat pose to half child's pose, to cat pose, to cow pose. And here we're really looking for the differences left to right, as also we can have a discovery of what the quadratus lumborum and the abductors are experiencing. So the quadratus lumborum is also a muscle in your lower back, and we can say we're experiencing the asymmetries even of the lower back muscles left to right when you set one knee forward of the other in this cat, half child's, cat, and cow pose sequence. Then we move from cat pose to plank pose. And if you actually do this from cat pose, and in our session we went from table pose, but if you do it from cat pose and you step 1 foot back towards plank pose, you're checking to see if there's even any veering side to side. And then you step back with the other foot and you're observing how the pelvis and the spine all respond to the movement from cat pose to plank pose, including the head. What happens with the head? Does it push towards the floor? Does the chin push forward? Does the student lift the base of the skull? Then you step down and you reverse. You step back with the unfamiliar foot and observe any veering side to side. And then you step back with the other foot and observe the same qualities of action. Now, if you go from cat pose to 1 foot back in plank pose, you might discover that your hip flexors are tight. If you go from table pose to plank pose, you'll have a different discovery. But I like this cat pose to one-legged plank pose to both legs plank pose because in 1 foot back in plank pose, you get to discover if the hip flexors are tight enough on that leg that's straightening to give you the sensations of stretching across the front of your hip flexors. Now, you'll miss that if you go from cat pose and you put 1 foot back to plank pose and you arch your lower back on the way. You'll miss the whole thing. So just be really sattvic in your attention and very elegant in your efforts. Then from plank pose, we check 1 knee to the chest, noticing the range of motion and also any compensation that's happening in the body. So going left to right, pushing your head towards the floor. Sometimes people bring the knee to the chest and they're able to arch their lower back as a counter action, as a compensation. We're not recommending that. You just want to take notice if when someone brings the knee forward and they arch the lower back instead of keeping spinal flexion, they're relying on different muscles to hold the pose. And this is also signaling you about the relationship between the student's hip flexors, glutes, lumbar spine, psoas, pelvic floor, the whole concert of actions. We also used mountain pose to upward hands pose to chair pose as part of our assessment. We inhaled to raise the arms up, we exhaled to sit down to chair pose, we inhaled to go back up. And then we reversed the breath strategy, and you observe the differences. Particularly because on the inhalation, the breath ought to be able to lightly touch the pelvic floor. A little bit of pressure should be tolerated by the pelvic floor. And then on the exhale, a little bit of tone comes to the pelvic floor. So when you're exhaling to sit down into chair pose, it'll feel more natural to do it that way because we've done it so often. But you also have the benefit of the pelvic floor getting slightly toned. So if instead you inhale to sit down to chair pose, your body has to maintain pelvic floor tone while allowing for some elasticity as experienced by the pressure of the inhale, and a little elasticity when you're sitting down into chair pose, because there is a little more pressure going down into your pelvis. So in either case, we're switching the breath to explore the differences for the student's experience of the movements and the pelvic floor, including the movements of the mind in response to changing the breath pattern. So all of that's a part of our consideration. And then we're looking structurally also at what happens to the lumbar spine, thoracic spine, as well as their outer hips, their inner knees, inner arches, and outer heels. We also used an assessment in mountain pose to upward hands pose, and then we stepped backwards to those lunge poses in the sun salutation. And what you're doing there is looking for stability in the transitions. We need the sattvic attention, the elegant effort, and the real study of self going on in these slower transitions linked with the breath. I hope you're still practicing some of those things yourself to get a real sense of how it can both develop your awareness and it can be part of the healing and re-strengthening and balancing of your body. We use Warrior 2 as an assessment as well, and we just did one of these particular assessments, but I want to give you all three to think about here. So we assess this and we change the length of the stride in our assessment. So it takes some time to get the assessment, but it's so valuable to sense when does the acetabulum and the femoral head, when do they hit up against each other? When are they kind of knocking into one another? As I called it the Star Trek Enterprise, when does it knock against the inside of the hip socket? So we have three observation ways to do it, and I call these like the three wheels. One is when you're in Warrior 2, you look at the anterior and the posterior pelvic tilt. And if we go slowly through both of those and really notice in the anterior tilt or the posterior tilt, when does it feel like the student or you get to the bony end range? Like it's not musculoskeletal, you might have tight muscles, of course that's going on for some of us, but what is happening in the bony end range? When do you feel like bones are hitting bones? So this is anterior posterior pelvic tilt, kind of like the wheel on your bicycle, going forward, or even if you ride backwards, sometimes going backwards. And then range of motion from what I've called 0 degrees, which is not a possibility, but it's helpful if you think of it like a protractor. We go from 0 to 180. These are in parentheses because there's no such thing as 180 degrees for Warrior 2. Please don't try it. It's not that important to get to this elusive 180 for the pelvis in Warrior 2. But what we are looking for is, let's say that you're standing with your right foot forward in Warrior 2 and your left foot back. So you've got your right leg as the front leg and your left leg as the back leg. And we're asking, if you rotate this pelvis as far as it goes to your left, and then as far as it comes forward, and you go really slowly, you're rotating like the large steering wheel on the very large buses, like a Trailways bus. The steering wheel is sort of facing, it's horizontal to the floor, and so they turn it the way that you're going to turn the pelvis for this assessment. And we are really asking, when, again, does the femoral head hit the acetabulum? Or vice versa. When does it feel like the acetabulum just bumped into the femoral head? So that's a different place to check, 0 degrees to 180 degrees, knowing that neither 0 nor 180 is realistic. And then the range of motion side to side with the hips is this kind of raising the right hip or front hip up, or then raising the back hip up, and observing when or if, again, the bones collide with the bones. And this is more like the movement of the steering wheel in your car. And this actually gets overlooked a lot in Warrior 2 because teachers are distracted by the pelvic tilt, the first steering wheel, or by how open or not open the hips are, the second steering wheel, and they'll miss the third one here. But it's super critical for hip replacements because what you're looking at is bony end range has been getting less. It's lessening as the bones experience more bone spurs, and it's lessening as pain comes on because the body doesn't want to keep putting itself in pain. You're also looking at it in this particular one because in Warrior 2, the back hip will likely, for some of your students, come into a bony end range where they are not able to level the pelvis left to right. And it could be they're making all the effort they're able to do and they cannot lift the front hip bone off of the front thigh bone because in the back hip, in Warrior 2, there is a bony occlusion. So take notice of that as well. We also do an assessment that we didn't have time for in our class. It's called Reclined Warrior 2 Pose, and we do it with partners and many blocks and such, and hopefully someday I'll have the chance to show you what that looks like. It's a really great discovery about the hip sockets and the pelvis, but it is time-consuming and it requires a lot more blocks than we had at the conference. But the next time you see me in person, you can ask me about it. Then we have a strategy called strengthening and lengthening. Which muscles need to be strengthened, which ones need to be lengthened. And we spent quite a bit of time on your blocks for your feet. So we did some myofascial release for the feet, blocks and tennis balls for the feet. And that was really important because it gives you a sense of how to do myofascial release. but also because the arches of your feet are talking with your pelvic floor when you're walking about in day-to-day life, as well as when you're running or doing other sports. So we did spend some time on that, and then we moved it up into the pelvis, and these deep six muscles, because of where they attach, we're able to do some work on some of these muscle fibers, and others we can't access. So this particular work with the tennis balls and the blocks was an effort to get into the edge of the sitting bones where the deep six muscles are attached, and to get into the edge of the sacrum where the piriformis, one of your deep six muscles, where that one is attached. Now these muscles go over and hook onto the greater trochanter, that is the outside hip bone, the bony thing you can feel with your fingers to the outside of your hip socket. All six of these muscles are like the rotator cuff of your hip joint, and they all add to external rotation to help stabilize the femur in the acetabulum. Now, all of them do external rotation, and they're very deep to the hip socket, but they can also be weak, or they can be short and weak. We might call that tight and weak. There's an exception for one of these muscles, and that's when you bring your leg forward, piriformis becomes an internal rotator, and this is something to understand as more of a nuance when you're working with students or clients. I'd like you to start by understanding that the piriformis is an external rotator, but when your leg comes to the front position, because of where it's attached to the sacrum and the greater trochanter, it does become an internal rotator. And it's part of the dilemma that we face in the poses called Half Moon and Warrior 3, when the student can't stand with stability on their standing leg, or they start getting a cramp in the muscles of the standing leg. Now, let me just take a little diversion here and say that the muscle fibers that we can't get to is really important to understand. In a hip replacement surgery, it's relatively common that a muscle called obturator internus can be adversely affected by the hip replacement in that it tightens up, it guards against the trauma of the hip replacement. And even though the hip replacement is a wonderful surgery and people are looking, to heal and come back to wholeness, there is a trauma when you, how shall I say, when you saw the head of the femur off of its root base there, and you have to get the thigh bone out of the hip socket. You've got to pound the titanium down into the femoral head. There is a trauma going on for the body in there, and so some of the deep six muscles respond to that trauma because, well, they all respond, but they respond because they're innervated with the pelvic floor, and your pelvic floor is one of your trauma-informing muscle groups in your body, which is why a lot of us have hypertonic or hypotonic pelvic floor muscles, and we actually don't know it, and it is affecting our mental health as well. So because we can't get to the obturator internus ourselves, I frequently recommend to my hip replacement students that they see a pelvic floor specialist, someone who does internal pelvic floor therapy. Where we were working with the tennis balls was alongside the insertions of these muscles just outside the sitting bone. And then we went across the piriformis to the greater trochanter. So one more thing to notice here is that the antagonists for the deep six, the internal rotators, and that includes your gluteus minimus, your tensor fascia lata, which is the muscle that becomes your iliotibial band, your IT band, and then the forward fibers or the front fibers of the gluteus medius, they're all internal rotators, and piriformis when your leg is in the front position, in the front plane of the body. Now here's an interesting way for you to assess the strength of your deep six muscles. This is just one way to do it, but if you have somebody lying on their stomach and they bend, in this case this is my friend Jennifer, and she's bent her left knee here, her left shin is tipped out towards my right hand in this illustration, and that's a TheraBand that I'm holding in my right hand. It's a little bit baggy right now because she's tipped her left shin out to the side. So her job is then to quietly bring the left shin up to vertical, which is going to have her go from internal rotation to neutral. Then she's going to cross her left foot over the midline towards external rotation. And when she's doing that, we don't really want her to get into arching her lower back or making a lot of effort with her elbows or having to use her inner thigh muscles, but to really go elegantly and quietly with the left deep six muscles. And she might feel those as these small muscles deep inside her left butt that are getting toned. it should not feel like a whole body activation because it can be quite a subtle thing. So her left shin would pull across to the opposite, and then she would slowly tip it back out to the left, having some control over the movement in both directions, which means as she brings her left heel from the out position she's in now to neutral and then across, she is toning and shortening the deep six muscles. And then as she takes her left heel back to the starting position, she's keeping the muscles toned while they're lengthening. So she's lengthening them and strengthening them at the same time there. She's keeping them toned while they're getting longer again. Right? So we might call them, they're going to get slack if she's lazy about it. So when she brings it across, muscles get shortened. We call that concentric contraction. When she brings it out, the muscles are going back to their lengthened position and we're keeping them toned. That's called eccentric contraction. We also want to be lengthening and strengthening the abductors. And the abductors are so significant in hip replacements. Every student that I've seen who's come in before their hip replacement has had both deep six, pelvic floor, and abductor dysfunction. So these are often weak due to pain and atrophy, and the bony developments inside the hip joint have been changing the way the person walks for a long time. And at the same time, weak abductors could be part of this person's genetic composition, which sets up walking habits that aren't optimal. And then people experience these shifts in their hip sockets. Now, gluteus medius is the most well-known of your abductors. It happens to be pretty large, and you can feel it if you place your fingertips on the greater trochanter and the heel of your hand kind of on the upper part of your ilium. Your hand will be covering the region, the geographical region of the gluteus medius. And we check the strength of the gluteus medius in our assessment program. We check it when the person is in internal rotation and when they're in external rotation. And we have specific strategies for doing that. And that's an important thing for us to realize because the gluteus medius does function differently in internal, neutral, or external rotation. We didn't have time to cover that specifically in our work together because it gets to be very nuanced and it's hard to teach specific nuance in certain sizes of classes like we had together at the festival. The antagonist for this muscle group is called the adductors. So we say abductors or abductors and adductors or adductors. They're your inner thigh muscles. So here is a little strengthening exercise for your abductors and for your deep six. So you start lying on your left side. As you can see, that's me lying here. And you bring the knees up toward the chest, and please stack the hips, the thighs, the knees, the shins, and the feet. And then you keep the feet together. You can see that when I pick up my right knee in the second photograph, I've still got my right heel on my left heel. That means that you're abducting your right knee up towards the ceiling, and you are slightly externally rotating your femur. So you've got your abductors and your deep six then. And then you go slowly back down to the starting position, and you can work it just like this in relationship to gravity. So no need to add a TheraBand. Or you can see in the third picture that there's a TheraBand tied around my knees. So that is an option as well. So the curious thing about this is that if there's hip dysfunction, frequently the thing the person does the most and has no idea that they're doing until we help them in our yoga therapy role, they go to pick up the top knee, in this case the right knee, and they do it by leaning back. They lean the right hip back and the right knee goes up. And this can be just a very slight sense of leaning back, or it can be very obvious, or somewhere in between, of course. So you're checking that someone's not leaning back to pick up the right knee. And a way to say that to people is to ask them to lengthen from their right hip socket into their right knee as they're raising the leg. So as they raise the knee, it should not feel like the right knee is sort of telescoping in, but almost more like it's telescoping out. It doesn't have to push the right hip forward, but we want it to stay really stable in the pelvis and get a good sense of how the deep six muscles act like the door hinge for the door frame. In other words, when you open the door, you're hoping the door hinge is going to be stable on the door frame, and that what moves is the door, not the door hinge and not the door frame. So this is the same analogy we use for the hip socket there. We also want to be able to strengthen and lengthen the gluteus muscles. So here you're going to see us We did some of those tennis ball and block exercises. We used myofascial tools like a foam roller to help with some of the lengthening of the gluteus muscles. And of course, we stretch them a lot in yoga. But what we're really going to focus on here in this particular discussion is why are we strengthening the glutes and why is it so critical for hip function? So when hip dysfunction is present, very frequently, the person's hip flexors have become shortened and their glutes are getting weaker. Now sometimes you'll see that they're doing just fine walking about because they've acclimated to it, but they're actually walking more from their calves and less from their hips and pelvis. So what we see, of course, in our culture that sits a lot is that people do have shorter hip flexors and they have weak butt muscles. We have weak glutes. So, for example, when you stand up in mountain pose, to know what the antagonists are, if you pick your right knee up towards your chest in mountain pose, you're going into hip flexion. And your hip flexors have to pick up your right knee, and your glutes need to let go to allow your right knee to rise up towards your chest. Your hamstrings also need to be a little bit considered here. But as you're doing that as well, the lower back has to be considered. That it's going to be able to lengthen enough for the right knee to pick the right knee up towards the chest. And then if you place your right foot back down in mountain pose, if you think of stepping your right foot back behind you, you'd step backwards with your right butt muscles. And your right glutes would have to be willing to let you do that. If you think of when you have your right leg stepping back into a lunge pose, it's going all the way back into hip extension. And yet, if the hip flexors are tight and the glute muscles are weak, we end up seeing a lot of people do that pose with their backs overarched. The lumbar spine is in too much extension. So this whole relationship between extension and flexion gets also quite nuanced because you've got 3 hip flexors to consider really strongly. Also the psoas, we can't leave it out, but the hip flexors that we're looking at with the glutes here as antagonists include your rectus femoris, your sartorius, and your TFL, which also becomes your IT band. So the glutes, the gluteus maximus and the gluteus medius, are antagonists purposely for these hip flexors. Then the hamstrings are also, they're capable of bringing your leg into hip extension, and we tend to see that they're tight for lots of people, but they're also weak. So they need lengthening and strengthening, and the hamstrings also play a role in our gait and in our stabilization. And you're going to see this in the next slide, looking at a way to strengthen the glutes and the hamstrings. You can also address the abductors and the deep six here, and I did that by adding a TheraBand to the knees for the person on the left, who happens to be me. So in this bridge pose, what you might notice is that the rib cage and the chest are not that much of a focus. Neither Jennifer, who's on the right, nor me, who's on the left, have lifted the chest all that much. We're focusing in this bridge pose on the lower hemisphere of the body. Notice that for both of us, we're opening the front of the pelvis, so there's no hip flexion in these bridge poses. It's all hip extension. So in the picture on the left, you're going up from the floor to bridge pose, and the knees press out against the TheraBand, and you've got this slow activation of the glutes, the hamstrings, the abductors, the deep six, pelvic floor. And ideally, actually, the sequence of muscles turning on is going from your pelvic floor to your deep six, to your abductors, to your glutes, to your hamstrings, and then up you go into bridge pose, pressing out against the TheraBand as you rise. And then on the right side, you'll see that Jennifer's doing this with one leg. So we take the TheraBand away. She's doing one-legged bridge pose. And you're really, again, coming back to the quality of attention and the elegance of effort here. And we're observing for if the hips veer left to right in picking up the pelvis. We also have to observe if she drops the left hip while picking up the right hip. And we need to observe if she arches her lower back a lot on the way up. Each one of those compensations will indicate a dysfunction in the muscle concert or the muscle conversation in her body. She's doing a good job here staying in alignment, so you don't see those misalignments in particular here, but as we teach people how to assess for that dysfunction, we look very closely at the alignment of the pelvis in all 3 of its wheels that we talked about in Warrior 2. And then we also want to have enough tone and enough length in the abdominals. So transverse abdominis is a muscle that in tandem with the pelvic floor, they really work together. In fact, it's a way to assess pelvic floor function is, does the student have good transverse abdominis function? Happens to be the same muscle that you would use to sing a long note. So the transverse abdominis is sometimes called the singing muscle, and it provides deep belly tone. And so if you picture singing a long note, like and really carrying that on through the length of your exhale, you'll start noticing the TA, transverse abdominis, is getting more and more toned, but slowly. And along with it is coming the pelvic floor. In ideal function, we're getting both of those things to work. Or you'll notice that you don't have that kind of leadership with those muscles, and you're using other muscles to try to make it happen. So actually, I think that chanting in yoga practice is so helpful to people because of things like singing affecting the transverse abdominis and the pelvic floor, and also how singing affects the two hemispheres of the brain. And we use chanting in classical yoga to have a way of pacing the breath. It's also great to bypass the thinking mind. Another group of muscles to consider are your obliques, which we add in for stability and also support our cross-crawl patterns. And there's a whole science on this thing called the contralateral slings, which we didn't get a chance to cover in depth. We do in our yoga therapy training. But just as a little hint, those lunge poses that we do, and even the warrior two pose, because they're asymmetrical, and because they include a cross-crawl pattern, you're trying to address this thing called the contralateral sling. And it's fascinating to notice if somebody's posterior contralateral sling is out of balance, what's happening with their glutes and hamstrings, and then crossing the back of the body, what's happening opposite in the latissimus dorsi or the quadratus lumborum. We look on the front side from the obliques and then to the opposite quads, and it's a fascinating science, and we do cover it in our yoga therapy training. It takes a little while to unpack it, but it's so valuable to know as a yoga teacher. And then the rectus abdominis, which most people think of as their core, and it's not, also known as the six-pack abs. This is less of a consideration in yoga therapy for hip replacements or yoga therapy in general, because we really need to have the TA, the pelvic floor, the obliques turned on first, and rectus abdominis is for deeper function, like you go into more advanced yoga poses, such as crow pose. You'll need your rectus abdominis for that, and some other things, but I don't want students firing there first because sometimes they're doing it first in the absence of other muscles deeper than that functioning well. And then we have the antagonists, so just to know, these include your paraspinals, your quadratus lumborum, latissimus dorsi, and your spinal extensors. And here's some fun ways to strengthen the abs, and we didn't do this in your workshop, but we did one knee to chest plank pose, and that's a cross-crawl pattern also. But this is even more beginning than that and pretty accessible to people. So if you place somebody in table pose, and you come back again to the sattvic quality of attention, so their mind becomes very present, and then you bring them into the elegance of effort, so they're getting the breath to flow smoothly and deeply. And then you ask them without jostling about. So now you've got these two hip sockets and two shoulder joints. Without jostling the bones against the bones, can they quietly lift the arm out to the side on inhale or on exhale? And can they quietly return the arm back to table pose? And it turns out that just moving one arm out to the side, you've got this cross-crawl pattern, which you'll notice in the hand that stays on the floor and the opposite knee. So if it's your right hand, it's your left knee. You'll notice those two becoming more firm against the floor if we haven't veered the hips side to side, if we haven't jostled the body or arched the lower back or lost the head alignment. You'll notice this cross-crawl pattern comes on. And ideally, a student can take their arm out to the side and bring it back to place it in table pose without having to hike the shoulder up to put the hand down. So we're looking for the smoothness of that action in this cross-crawl pattern as well. And then here we use a TheraBand, and we practice stepping backwards for this cross-crawl pattern. So this student has both arms out in front, and when she steps back with her right foot, she pushes her right hand forward and pulls her left elbow back. When she steps forward from there, she brings the arms back to the starting position. And we do this also slowly, so you can sense how in her left hip, she's going to need her pelvic floor, her deep six muscles, her abductors. She'll need her left lower obliques, her left glutes, and her quads and hamstrings to participate together, so that when she steps backwards with her right foot, she won't lean sideways with her left hip to take the step backwards. She can move through the hip joint cleanly. When she places the right foot back, the temptation is to overarch the lower back, and if the hip flexors on the right leg are tight, you'll see that happening. So when she's stepping forward, she's going to need the same sequence of muscles on the left leg, and the forward step will include her right psoas to step her right foot back to meet her left foot. This is so worth trying, this particular exercise with a TheraBand. We spend time on this in our adaptive yoga module and our strength conditioning module because we use it for more than musculoskeletal function. We also use it for the cross-crawl pattern of the brain, the hemispheres of the brain. And here's adding instability to a pose that's familiar. So then we start adding instability. We call it adding instability because you can see my hands are on a balance board there. And you have to balance the balance board, but you can also try just tipping it very slightly left to right or front to back and keeping your plank pose super stable. Notice that in this plank pose, my lower back is not arching, and there's a line from the top of the head down through the back of the head, shoulders, hips, hamstrings, calves, and heels. So then our consideration for the hip flexors, and here I put all of the hip flexors. In an earlier slide, I didn't name the psoas because it is a spinal flexor and a hip flexor, and we were talking back there about hip extension and flexion, and I focused on the glutes and the direct antagonists for that. But here you've got rectus femoris. It's the longest of your quad muscles, and the only quadricep that crosses into your hip. The other three quadriceps do not come up into your hip bone. They stay just on the thigh bone. And rectus femoris is the one hip flexor that does not add to rotation. Your sartorius is the longest muscle in the body. It goes to the upper outer ilium, which is your hip bone, and it crosses to the inner knee. So it goes diagonally down the front of your leg and attaches to the inner knee just where the shin and the knee come together. It's responsible for flexion, so it brings your knee to your chest, abduction, it moves your knee out to the side, and external rotation. It rotates your femur externally. It is the muscle that you use when you're sitting in a chair and you want to cross your right ankle over your left knee. You do all three of those functions at once: flexion, abduction, external rotation. The TFL becomes the IT band, and this is attached also on the ilium, goes down past your greater trochanter and down your thigh bone into the outer shin, just below the knee. Because of its positioning here, the TFL is also an internal rotator. So it does hip flexion, it also does abduction, so add that to your notes, and it does internal rotation. This is often the muscle that is cramping when people do half moon pose and they feel like they can't make it the way we did in our class. They can't get around the thigh bone and the hip socket without doing a counterbalance that inevitably causes their hip to cramp instead of stabilizing them. And then you have your psoas, which is also a spinal flexor. It's attached from the lesser trochanter, so that's the very, very top of your thigh bone on the inside, and goes as far up as T12. It goes up through your abdomen, on the vertebrae, on the sides of the vertebrae, up as far as thoracic vertebrae number 12, which is right near your diaphragm. And so the diaphragm and the psoas are sharing some muscle insertions alongside the spine. This is super important for how we breathe and how the psoas conducts our infant startle reflex response, which is also how it's conducting then our reaction to stress response. So when we get a flinch, like a psychosocial flinch, you have a little anxiety or a little apprehension occurs, that flinch includes your pelvic floor and your psoas and your diaphragm. And given that it's happening all day long, and because sitting in our culture also shortens the psoas, we do have a number of health concerns based on having a short psoas, a shorter, weaker psoas. So antagonists to your hip flexors include your hip extensors, your gluteus maximus, your hamstrings, and so on. So I'm talking your ear off here, and one thing I want to also mention for anybody that you're working with who's getting ready for a hip replacement, if they have been walking on the hip that's getting ready for repair, it's quite likely that their calf muscles have been helping them to walk. So we really focus on, this is all for pre-op conditioning, that we're looking at these specific muscle functions. And so we do focus on lengthening their calf muscles. We're lengthening the hip flexors, we're lengthening the calves to help their gait be a little bit better. But at the same time, we're strengthening the glutes and the deep six and the abductors. We're lengthening the adductors so that they can have a little easier time walking, but we can't leave out the calf muscles, which is why they're here towards the end of your slideshow. These muscles benefit greatly from the work we did with the tennis ball and the blocks when we were in class, because a specific muscle in the sole of your foot, called flexor hallucis longus, goes along the arch and then up the back of your calf. Right? And so you've also got how your walking is affecting your feet and how your feet are walking is affecting your hip. That's all tied together in there. Now here we're going to just reinforce strength, lengthening the adductors. When people have a hip replacement, often their adductors are tight following the surgery. So we're going to get them ready for that by lengthening the adductors before they go in. But often the adductors have gotten tight in response to weak gluteus medius muscles. So how a person is walking, their knees tend to collapse in more, or you'll see them in these yoga poses and the knee is dipping in Warrior 1 or Warrior 2 or even Warrior 3, and they're not able to keep it lined up. They can't aim their knee straight ahead because it keeps flicking back in to the midline. So we lengthen their inner thigh muscles, and then we do want to stretch the abductors so they can be tight and weak. They might not just be like overstretched and weak. So we do stretch the abductors, and we do some of that with our foam roller technology, which is not a part of this presentation, but is very extensive in our yoga therapy training. The foam roller is one of my best friends. So we are going to stretch the gluteus medius, and we're going to strengthen it. As well, we need to keep in mind about the lower back. Right, so we want to stretch the latissimus dorsi. It's a massive lower back upper trunk muscle, and it experiences some changes with the hip flexion and psoas. It's also one of your contralateral sling muscles. So we're really looking at stretching latissimus dorsi for a number of reasons. And then we want to stretch quadratus lumborum, which we looked at in the cat-cow pose and the asymmetrical cat-cow pose. So we do it. It's a back-bending, side-bending, rotating muscle, so we try to stretch it in flexion, in side-bending, bending away from the tight QL, and adding a little bit of rotation. And this is something you have to keep an eye on. When someone's gait has been changed by their hip condition, their calves are walking them. Frequently the calves are walking them, and the QL is getting tighter because they can't bring the hip into extension when they're walking, so instead they put the lumbar spine in extension. And so every step they take, they can end up with the lumbar spine arching for the leg that's in the back position on the gait, arching and slightly hiking the hip up to then bring the foot forward in their gait. So the calves and the QL cannot be overlooked in getting ready for a hip replacement. And then we do want to also lengthen the quads and hip flexors. And we use the foam rollers for this as well. We want to keep them all happy. Okay, so that's a lot of discussion about one specific area from our yoga therapy training. And in case you're interested, I put some information in here for you about the training itself. We do go much deeper in using our hands on techniques and also observation techniques and using the myofascial tools of the TheraBands, the tennis balls, the foam rollers. We use our balance boards and physio balls and so on. But we actually start with the sattvic attention. We start with elegance and effort. So we begin with a 4-day module on mindfulness-based yoga, integrating neuroscience and mindfulness, and really understanding the nature of the brain and the influences of trauma. So it's a trauma-informed module. It's 30 hours long. And this module prepares us to move into the next one, adaptive yoga, how to really adapt a practice to the person, having any number of conditions, including joint replacements. And we want to be able to have those two modules well enough established that when we then come into the strength conditioning model, we aren't doing it in what we call catabolic function. We're not approaching this strengthening thing with an attitude that's more adrenal or more catabolic. We're approaching it from the model of yoga, the lens of the koshas, sattvic attention, elegant effort. And then our final module in the first part of this training is called Ayurvedic Restorative Yoga. And this is so essential for life everywhere and all of us who have too much stress in our lives. But the Ayurvedic Restorative module is also really essential for someone getting ready for a hip replacement, experiencing chronic pain, recovering from a hip replacement or any other joint replacement, having difficulty realigning their pelvis in yoga poses. The restorative practice becomes very important for this also. There's a magic that happens in these Ayurvedic restorative poses. And then we move to part 2 of our training, which is 140 hours over 8 weekends with one 4-day immersion retreat at the end. And this one goes deeper into the yoga psychology and neurobiology, so using the Yoga Sutras, the Upanishads, the Bhagavad Gita. We go more deeply into the chakras, the vayus, the doshas, and so on. And also using Western psychotherapy principles, like attachment theory and co-regulation and interpersonal neurobiology and some other aspects of Western therapy as well. Shadow work, for example. So it's a pretty full-on training, and I welcome you to take a look at it on our website, sarahjoyyoga.com. Most of all, I welcome you to send us questions that you have about this discussion and anything that you have from the class that we took together at the Northwest Yoga Conference. And I'm glad you listened all the way to the end. I know it can be challenging, so I don't know how to make a whole video for you on this discussion just yet, but my colleague Nate, who was assisting the class, is pretty keen on that stuff, and I think I can ask for his help. So more resources to come for you guys. Thank you, everyone. Thank you very much. Namaste.